Hello, we will now begin today's webinar, Updates from ASPHO. A few housekeeping notes. All participant lines will remain muted for the duration of the webinar. To ask a question, please type your question in the chat box online. The presenter will read each question aloud at the end of the presentation. I would now like to introduce you to today's speaker. Dr. Susanna Kuntz currently serves as the principal at Kuntz Oncology Consulting, LLC, where she serves as a consultant for pharmacy practice, medical education, and clinical research in the fields of pediatric hematology, oncology, and HCT. Dr. Kuntz, you may now begin.
Okay, great. Thank you, Molly, for that wonderful introduction. And I'd like to thank all the participants for joining me today as I summarize recent updates from the 2016 ASPHO meeting. We'll get started. These are my faculty disclosures. I currently serve as a consultant for Sigma-Tau Pharmaceuticals as well as Amgen. I am on the Speakers Bureau for Shire. It was Baxalta, but Shire's now acquired that company. And I've received fees for non-CPE programming from BTG International. And of course, it can't be a pediatric talk without the final disclosure that I will be discussing the off-label use of agents approved by the FDA as well as those currently under investigation. So our objectives today I have here listed, and essentially, again, we're going to look at some of the innovations that were recently discussed at the ASPHO meeting, as well as how we can interpret some of the data that was presented and apply it to our pharmacy practice, because I think there's a really large role for pharmacists to play in the implementation of some of the protocols that were discussed, as well as the guidelines that have been recently published. So for those of you unfamiliar with the 2016 ASPHO annual meeting, this was a conference of the American Society of Pediatric Hematology and Oncology. It's designed to provide attendees with state-of-the-art subspecialty education. The meeting was held in Minneapolis, May 11th through the 14th, and the content that was included was 24 different symposia and workshops, 9 platform sessions, as well as over 360 abstracts were submitted to the meeting, of which 35 were selected for platform presentations and 300 were presented in poster format. Many of these sessions did occur concurrently, so unfortunately I couldn't attend everything, but I tried to pick the ones I thought were most pertinent to pharmacy practice. There was also the Pediatric Blood and Marrow Transplant Consortium, or PBMTC, meeting. They held their spring meeting prior to the start of this conference, and in the interest of time, I cannot discuss what was presented at that meeting in terms of transplant-related information, but they do have a meeting that goes on in concert with the ASPHO annual meeting. And just as a teaser for those of you interested, the 30th annual meeting will be next spring, April 26th through 29th in Montreal, Canada. So just to give you a brief overview of the webinar structure, as I mentioned, there were many concurrent sessions, and so I tried to pick the ones I thought were of interest to pharmacists, as well as ones that were presenting innovative data and information. So I teased things out into 4 different buckets, if you will. I put them in malignant hematology, solid tumors, supportive care, and then survivorship. There also were sessions on non-malignant hematology, such as sickle cell disease and vascular anomalies, as well as information discussed on quality and outcomes. But these were the 11 topics that we're going to be discussing today. Some, as you can see, listed in green were in papers format. The items that are listed in blue were presented in a 90-minute educational platform, and then the orange listed there were presented in poster format only. So we'll go ahead and get started with the malignant hematology portion, and I've selected 3 abstracts of interest that I will be presenting. The first one of which is the final phase 1 results of mitoxantrone in combination with clofazimine in children with refractory relapsed acute leukemia. This was one of 2 plenary paper sessions. So after all of the abstracts were submitted, the selection committees chose 2 submissions of greatest importance, and this was one of them that was scored the highest. So this is by Jessica Hochberg and Mitch Cairo out of New York. So for mitoxantrone and clofazimine for porous leukemias, just to give you a little bit of background, As we know, pediatric leukemia is the most common malignancy that we see in children. Fortunately, the 5-year overall survival rates are quite high. As you can see, for patients with ALL, it exceeds 80%. We're probably closing in on 90%. And for AML, a little bit lower, but still around 60% for 5-year overall survival. So most of our patients tend to fare well. Unfortunately, though, there are those subset of patients that ultimately will relapse after achieving a remission. In ALL, it's up to 20% of patients. In AML, it's almost half of the patients can experience or expect to experience a relapse at some point in their therapy. This is important because survival rates will decline with each subsequent relapse. In fact, when patients have ALL, if they're in their third complete response, they have less than 10% survival. These high-risk ALL patients are difficult to salvage, especially when they occur in older children and when relapse occurs early rather than later in therapy. With AML, the statistics are not as favorable, as I mentioned. When patients achieve a CR2, you have about a 30 to 64% achievement rate of CR2, and the median duration of CR2 is only about 12 months. We do have several salvage regimens for these patients, often re-inducing them with regimens that are Ara-C-based, but unfortunately there's really no one single regimen that is proven to be clearly superior in this patient population. I've given you some examples enlisted between ALL and AML of how we define certain patients as being high-risk leukemia. So we need better treatments that allow for us to salvage the patients without increasing the toxicity that we are seeing in the patient population. So the investigators decided to explore a combination of mitoxantrone and clofarabine for these patients. We do have experience in children with both of the agents. With mitoxantrone, there was a pilot study with cytarabine that produced an overall CR rate of 73%. As you guys are familiar, the CCG2951 trial produced a CR rate of about 70%. And most recently, the UK ALL-R3 trial had a 3-year event-free survival rate of 64.6% in patients receiving mitoxantrone, compared to only about 36% in those patients receiving idarubicin. This trial was actually stopped early due to the superiority of mitoxantrone. Clofarabine experience in children is quite robust. In fact, this agent was approved by the FDA in 2004, first in children, before it was approved in adults. Our single agent experience, the objective response rate is about 26 to 30% when clofarabine is given at 52 milligrams per meter squared per day. And in combination trials, etoposide and cyclophosphamide in combination with clofarabine, in phase 1, the objective response rate was 64%, and in the phase 2 study, it dropped slightly, but it was still quite robust at 44 to 56%. What's the rationale of using these agents in combination? Well, clofarabine inhibits both DNA synthesis and ribonucleotide reductase, and that acts synergistically with other DNA-damaging agents. We know from experience that cladribine and anthracyclines have demonstrated increased anti-leukemic activity in vitro. So with mitoxantrone, there's a synergistic effect during the induction of apoptosis, both in normal and neoplastic lymphocytes in vivo. So the investigators decided to undertake this study to look at mitoxantrone and clofarabine in combination, and they thought it would be safe and effective in patients with poor risk refractory and relapsed leukemia. So this was a phase 1 multi-center study to evaluate the combination. The primary objective, as you would imagine in a phase 1 study, is to determine the maximum tolerated dose of escalating doses of clofarabine, ranging from 20 to 40 milligrams per meter squared per day, given in combination with fixed dose of mitoxantrone at 12 milligrams per meter squared per day. Secondary objectives was to look at response rate as well as determine the extent of minimal residual disease following reinduction. Here is the treatment outline that the study investigators used. Clofarabine was given for 5 days, days 1 through 5. Mitoxantrone was given days 3 through 6 in combination with dexrazoxane to prevent cardiotoxicity. 5 days of dexamethasone was administered. Rituximab was given to those patients with large B-cell lymphoma, Burkitt lymphoma, or Burkitt-like leukemia. All patients received intrathecal therapy as prophylaxis. If you had all patients with ALL, Burkitt lymphoma, and Burkitt-like leukemia received intrathecal therapy for prophylaxis. This consisted of cytarabine if patients were under the age of 3. If patients were at least 3 years of age, they received liposomal cytarabine as prophylaxis. And then all patients received filgrastim starting on day 7 until their ANC was at least 1,500 for 2 consecutive days. So this was a standard 3+3 design and dose escalation, and I have here listed in the chart the different dose levels. And as you can see, the clofarabine dose was escalated with each level in fixed combination with the mitoxantrone at 12 milligrams per meter squared. They looked for dose-limiting toxicities, which they defined all grade 3 and 5 non-hematologic toxicities except for the nausea, vomiting, alopecia, and anorexia. Grade 3 and 4 infections, grade 3 and 4 transaminitis resolving to at least grade 2 or lower, and then grade 3 and 4 elevations in amylase, lipase, total bilirubin resolving to a grade 2 or lower. The plan was to carry forward the maximum dose associated with less than 33% of dose-limiting toxicities to Part B of the study. Here are the demographics. They had 18 patients, median age of 13 years of age. Half of the patients were male. Most of the patients either had ALL or AML, although there was one patient with lymphoma. And as you can see, there were induction failures, some patients in first relapse, and a few patients in second relapse when they entered the study. Most of the patients had an M2 or M3 mirror when they entered the study. The median prior anthracycline dose was 154 milligrams per meter squared, and the median starting shortening fraction was 37.5. 21 total cycles were given to the patients. The median time to neutrophil recovery was 24 days, and the median follow-up time was approximately 17 months. As far as response, of the 17 evaluable patients, 14 had a complete response. The investigators noted no difference in response rates between patients with ALL and AML. All of the patients went on to receive an allogeneic hematopoietic stem cell transplant. Nice bridge to stem cell transplant. Most of the patients were able to receive 1 cycle of chemotherapy, and then they moved forward quite quickly to stem cell transplant. And 93% of the patients achieved a complete response as defined by less than 0.01% flow cytometry. For toxicities, not unexpectedly, all patients experienced the expected grade 4 myelosuppression, as well as grade 2 to 3 transaminitis, all of which they returned to below grade 2 within 7 days. Other toxicities were bacteremia, hyperbilirubinemia, elevations in lipase, hyponatremia, and some mucositis as well. There were a total of 2 dose-limiting toxicities at dose level 4, which was the 40 milligrams per meter squared per day of clofarabine. One was a grade 4 hepatic toxicity that did resolve in that patient. However, it was not within the time frame stipulated in the study, so they had to grade it as a grade 4. Another patient had prolonged myelosuppression, but they were able to proceed to transplant even without count recovery. So the investigators found that the maximum tolerated dose was dose level 3 of clofarabine, 35 milligrams per meter squared per day. So this is a feasible combination. It's safe and well tolerated. There's now a phase 2 study open looking at the maximum tolerated dose of clofarabine at 35 milligrams per meter squared per day. And what is our pharmacy impact and why is it important? Well, this clearly presents a new treatment options for patients. So this is something that I think we should have on our radar as far as when we're trying to salvage patients or consider treatment options for patients when they do relapse. There's also opportunities for supportive care and treatment education. We have an opportunity for us as pharmacists to really get in with some of the pathways as far as treating patients when they do develop infections as well as prophylactic against infections, because this was a big concern in these patients due to the prolonged myelosuppression. Moving on to the next abstract, this was the best of COG. This session was actually organized to increase interaction between COG and ASPHO, since many people can't attend both meetings. So this information was presented to give ASPHO members an update of what's going on at COG. So the first one that I am going to talk about is AML committee initiative. And Dr. Gamis did a nice summary of all the AML trials to date and how the data that we have currently available is really helping us to form and shape our future trials. So for those of you who remember, probably about 12, 15 years ago, our standard treatment for AML was the AML 2891 study, or the doctor-doctor study. This has since evolved, and we now know that we don't just treat all AML patients the same way, but rather we can tease them out into 3 separate groups. And so we have myeloid leukemia of Down syndrome, we have acute promyelocytic leukemia patients, and then we have the other AML patients. And here I have listed the evolution of the trials in each of the 3 areas. But the one trial I'm going to focus on today is AML 0531. So as you remember, this was a study that looked at adding gemtuzumab, and it found that adding gemtuzumab to chemotherapy improved event-free survival through a reduction in relapse risk for children and adolescents with AML. What did we learn from the study? Well, we learned that gemtuzumab does not improve remission rates, but rather its benefit is seen by reducing risk for relapse. And it does so across a wide variety of patients. Patients that are low risk, such as patients with core binding factor AML, intermediate risk patients who go on to receive a matched family donor hematopoietic stem cell transplant. So if patients did not go on to receive a transplant, they didn't see the benefit. And then we also saw benefit in high-risk patients with FLT3 internal tandem duplication, and those patients who went on the transplant. We still have unanswered questions, though. How do we determine the patient's expected benefit from gemtuzumab therapy? And we know that there's significant heterogeneity expression of CD33 within populations of AML. So does this correlate with efficacy? So Jessica Pollard and colleagues looked at this as the a priori of high CD33 expression correlates with benefit. And this is a publication, this data comes from a publication that was appeared in the Journal of Clinical Oncology earlier this year. And what they did was they took the patients on the 0531 study and looked at their expression of CD33. And this was measured by mean fluorescent intensity. And they parsed out the groups into 4 different groups or 4 quartiles from lowest to highest. And they found that if patients had low expression of CD33, so those patients in the first quartile or the lowest expression, adding gemtuzumab had no effect on relapse risk as well as event-free survival. But when they looked at the patients with higher levels of CD33 expression, so those were the patients in the second, third, and fourth quartile combined, adding gemtuzumab did have a benefit and did improve the risk, relapse risk as well as event-free survival rate. They then went on to look at outcomes in relation to patients who have high CD33 expression. So these were the groups, the second, third, and fourth quartile groups, and they said, does it matter what type of leukemia they have, what risk factors they have, so the cytogenetics. And they parsed them out into low risk, intermediate risk, and high risk. And pretty much across the board, they found that, yes, adding gemtuzumab therapy improved either the relapse risk rate or disease-free survival in these patients. So what is the aim for our next study, which is right now being considered as AAML 1731? Todd Cooper and Jessica Pollard are going to be the co-PIs on this study. We are now renewing an anti-CD33 target focus. We want to be able to enhance gemtuzumab's efficacy, so we want to determine the best methods for dosing and administration, as well as increasing target expression. What we have learned is by giving gemtuzumab in induction only is probably as equally benefit than if you were to continue more doses after induction. So this study is going to just looking at giving doses during induction on days 4, 7, and 10. It also will be looking at giving azacitidine to patients And that is to prime patients because it's been found that azacitidine can rev up CD33 expression if given before gemtuzumab. So that is the study backbone that's being considered for the next trial. What's our pharmacy impact? Well, for one thing is drug access. As you are aware, gemtuzumab was withdrawn from the U.S. market in June of 2010 due to a lack of clinical benefit and some safety concerns. So for us to be able to give it to our patients, it's only available for investigational use via an IND application process. We also know that because we continue to do studies, we have a big role in patient monitoring and education of our patient population. There was a recent publication in JCO by Miller and colleagues looking at underreporting of and underestimating rates of adverse events in patients with AML. They found that a lot of the adverse events are very complex to evaluate and be lengthy and to report, so there can be some underestimation. So they suggested looking at electronic format and reporting the incidence of AE. So that's something I think pharmacists can really become a part of and jump on. So now our first ARS question. So the benefit of adding gemtuzumab to chemotherapy in pediatric patients with AML is seen by improvement in event-free survival through a reduction in relapse risk, event-free survival through an increase in complete remission rate, disease-free survival through an increase in complete remission rate, or disease-free survival through an increase in likelihood to receive a stem cell transplant. Okay, give you a few more seconds. And so, yeah, the answer is A, event-free survival through a reduction in relapse risk. So the last malignancy, hematologic malignancy abstract that I'll talk about was a poster looking at the feasibility of outpatient high-dose methotrexate in patients with B-cell lineage ALL. As we know, high-dose methotrexate over 4 to 24 hours is the mainstay of interim maintenance therapy for pediatric B-cell ALL. But it often requires an hospital admission until adequate methotrexate clearance. The investigators thought that outpatient administration could be an attractive alternative. So they looked at giving 5 grams per meter squared of methotrexate over a 24-hour continuous infusion in the ambulatory setting. And this was a randomization of patients aged 3 to 17 with de novo high-risk ALL. They were randomly assigned to receive their first cycle of methotrexate either as outpatient or inpatient, and then their next cycle was flipped into the alternate setting. And each patient served as their own controls in a matched pairs analysis for each comparison. Home health did provide some of the materials as well as supplies, as you can see here, and this is the data that was collected. For those patients in the outpatient setting, they used a standard form that was provided by the investigators to record the incidence of emesis of the use of antiemetics. Here are the results. The first 4 indicators here is what the authors termed as safety measures. As you can see, there's really no difference whether the patients receive the therapy inpatient versus outpatient, with the exception of antiemetic use. So the number of emetic episodes were similar between the 2 different groups, but there was a significant decrease in the number of doses of antiemetics used in the outpatient setting. Could this have been due to a reporting bias or incomplete reporting? The investigators really didn't speculate, but that's something to consider. The last 2 indicators are what the cost indicators, and as you can see, there was a significant reduction in out-of-pocket expenses and billable charges between the 2 groups. In fact, the cost of care, there was a 10-fold difference here between inpatient versus outpatient. So this study, although it was quite small, there was only 5 patients who received a total of 6 courses of the therapy. They found it to be safe, cost-effective, and they do recommend that further study is being warranted. As we know, high-dose methotrexate has been done in osteosarcoma patients. The group at Memorial Sloan Kettering as well as Montefiore Med Center, both in New York, have been doing this in the outpatient setting for osteosarcoma patients, and they find it very feasible. So as far as pharmacy impact, this is something for us to consider. It would result in changes to our care delivery model, both in cost and resources. But it's something I think we really need to thoroughly think through looking at high-dose administration of the methotrexate at home. I did include an appendix with the handout, and I walked through some of the questions that you may want to consider when you're deliberating whether or not to give something like this type of a regimen in the outpatient setting. So there's several policies and procedures that need to be in place. You really need to identify the right patients to receive the therapy, and probably look for a liaison or educator between the hospital, the clinic, and the home infusion, because I know a lot of questions will arise if you start doing this. Now moving on to solid tumors, the first abstract I'll talk about is the use of gemcitabine and nab-paclitaxel for pediatric relapsed and refractory solid tumors. As you are aware, pediatric patients with relapsed and refractory solid tumors have very poor outcomes. Therefore, of course, there's a need for novel therapies. But since many of these patients are at the end of their life, we do have to be very cognizant about preserving their quality of life. So if we can avoid hospital admissions or increase in adverse events, that's going to be very helpful for these patients. Gemcitabine and docetaxel has been studied in adult patients with sarcomas, but there have been 3 retrospective analyses looking at efficacy in children with sarcomas, and it's proven to have anti-tumor efficacy with a favorable toxicity profile. But more recently, nab-paclitaxel has been entered onto the market, and this is quite advantageous because since it's solvent-free, you have a decreased risk of hypersensitivity reactions, and because it's albumin-bound, this allows for a higher maximum tolerated dose of drug delivery compared to paclitaxel. We have experience with the drug in a variety of pediatric solid tumors. So the investigators decided to take this investigation under consideration, and it was a retrospective analysis of their patients between 2010 and 2015. They did not have any published data, so that's why they went ahead and collected their data at their institution. They looked at the treatment of gemcitabine at 1,000 milligrams per meter squared IV on days 1, 8, and 15 in combination with nab-paclitaxel, 125 milligrams per meter squared on days 1, 8, and 15. And in their institution, 12 patients underwent this regimen. And this was based on the pancreatic adenocarcinoma trial. It was noted that 3 of the patients received a slightly different regimen where they received the same drug at the same doses, but day 8 was omitted. And this is due to the fact that they were reaching the end of life and they wanted a therapy to be given in a fashion that would increase their quality of life. So it was decided to omit day 8. That saved 1 trip out of each cycle to the clinic. So the study didn't set out to compare regimen A versus regimen B, but this was just an observation that they noted. So here are the results. Median age is 15 and a half years. As you can see here, the patient characteristics, most likely the patient had a bone or soft tissue sarcoma, and they could receive concomitant therapy. A few patients got radiation, oral agents, and surgery. It was noted that if patients were given radiation, that the gemcitabine was either held or given at a 50% dose reduction, but that was up to each individual treating physician. So the results, they had response evaluable in 14 of their patients, and then using the RECIST criteria, they found a 7% objective response rate. Their median progression-free survival was about 2.1 months, but at the time of presentation, 2 patients have yet to progress at 3 and 6 months since starting therapy. Median overall survival was about 6.6 months, and the median follow-up was about 14 months. And at the time of presentation, about 20% of the patients are currently alive. Here are the grade 3 and 4 toxicities. Not surprising, it's hematologic, it's the most common. They did see a few hepatic toxicities, all as AST, ALT elevation. 3 patients had infections, but no culture-positive bloodstream infections were noted. There were 2 cases of myositis that rapidly resolved with oral dexamethasone, and 2 patients had grade 4 toxicities were non-hematologic. 1 had respiratory distress that was in the setting of malignant pleural effusion, and 1 experienced septic shock, although a full infection evaluation was negative. What was interesting is none of the patients experienced peripheral neuropathy. If we go back to the adult data receiving gemcitabine and nab-paclitaxel, it can be expected that about 20 to 30% of these adults will have a grade 3 or 4 peripheral neuropathy. But in this cohort, again, very small numbers, but still no one experienced peripheral neuropathy. Teasing out the hematologic malignancies a little bit more, as you can see, neutropenia, anemia, and thrombocytopenia was reported. But what was interesting is that the patients on this regimen B, where day 8 of the agents were admitted, they did not have hematologic toxicities as significant as the patients that got days 1, 8, and 15 of the drug. None of the patients stopped the trial due to toxicity. Patients only stopped the study drugs if they did progress. So the authors found that this was a reasonable palliative option for their patient population. There are future plans to do a prospective evaluation, and they did have some limitations. Again, limited number of patients, it was a single institution, but hopefully if they advance this to a phase 1 clinical study, we can get some more robust data. Our pharmacy concern, or what's impacting our practice, well, this gives us a new treatment option for this patient population that is very high risk for not being able to be salvaged. So opportunities for us to, create order sets as well as patient education sheets for patients receiving this. So our audience response question number 2. Which of the following adverse events reported in adult studies with gemcitabine and nab-paclitaxel was not reported in children by Metz and colleagues? Is it neutropenia, anemia, myositis, or peripheral neuropathy? And that is correct. The majority got it right, peripheral neuropathy. So that's something that we did not see. So if we have larger numbers of patients, maybe we might be able to see something. But at least for right now, we don't have to reach for the gabapentin per se to help treat and manage these patients. So moving on, the last solid tumor area that I will talk about is the thyroid cancer. Thyroid cancer in children, as you may be aware, it's most common to have differential thyroid carcinoma, or DTC. And specifically, papillary thyroid cancer occurs in about 90% of the cases reported in pediatric patients. Follicular thyroid carcinoma is rarer, less than 10%. Medullary thyroid carcinoma and anaplastic thyroid carcinoma, which have been reported in adult patients, rarely do we ever see these in children. So really, when we're talking thyroid cancer, we think of papillary thyroid cancer in our patient population. So what's new? Well, for one thing, we're starting to see an increasing incidence in thyroid cancer, especially in adolescent females. Not clear as to why this is occurring. Some people speculate it's due to increase in surveillance and looking at the patient population when we do a lot of our evaluations when they come in with a thyroid nodule. But we do see an increasing in incidence that's being reported. But we've had a recent publication of guidelines. In 2015, so last July, the first time the pediatric-specific guidelines were published. And I have them referenced there by Francis and colleagues. This is a 44-page document, has more than 34 recommendations on how to manage pediatric patients with differentiated thyroid carcinoma. The previous guidelines, to compare, pediatrics had 1 paragraph in the guidelines that were published in 2009. So I think this is a huge leap for pediatric patients to have not only our own separate guidelines, but such an extensive guideline. Why the need for our specific guidelines? Well, there are some similarities between thyroid cancer in children and adults, clinical presentation, ultrasound features, for example, but there are also a lot of differences as well. Although clinical thyroid nodules are very uncommon in children, the risk for malignancy is higher in pediatric patients compared to adults. Children are more likely to present with increased metastases, and oftentimes this is due to the fact that children have asymptomatic masses that aren't evaluated as rapidly or as readily as adult patients are. They also have higher recurrence rates, but there's a very low disease-specific mortality. So about 98 to 99% of our patients will survive. So with these guidelines, historically what we used to do is took a very aggressive approach. Patients went in, didn't necessarily have a fine needle aspirate biopsy, but they went in, had surgery. Oftentimes it wasn't complete surgical resection, and that was then followed up with radioactive iodine for most of our patients. But we're starting to become more refined in our management. And again, the goal of these guidelines is to reduce complications while maintaining low disease-specific mortality and avoiding increase of persistent or recurrent disease. So just to highlight these guidelines, looking at nodules, they're asking which patients require a fine needle aspiration, and how do you stratify surgery based on those FNA results. When we talk about surgery, do all patients benefit from the same procedure? So historically, patients would go in and have a thyroidectomy. Do we need to do that on all of our patients? Are there some patients who can just have a lobectomy and be fine? And then how do we stratify patients based on the lymph node dissection? Do we have to remove the lymph nodes in the central neck on all the patients? And which patients should have removal of lymph nodes from the lateral neck? So these are questions that the guidelines put forth and give us some guidance for. And then finally, radioactive iodine. Do all of our patients benefit? In the past, again, most of the patients are given radioactive iodine, but can we limit the use of it? And for those patients who go on to receive it, how do we best administer that? What's the amount that we give? What's the frequency? Also that was discussed in this educational program was looking at oral tyrosine kinase inhibitors for thyroid cancers. In adults, there's a plethora of drugs. So for differentiated thyroid carcinoma, we have sorafenib and lenvatinib. For medullary thyroid carcinoma, FDA-approved mandatinib and cabozantinib. As you see, nothing approved for pediatric patients. Many children don't necessarily need medical therapy, but there are a few that do. And those are if they're radiorefractory differentiated thyroid cancer with evidence of clinical significant disease progression. But we unfortunately have a limited amount of data of using these agents in children. What I was able to locate was probably the most use with sorafenib. There's been some case reports for the treatment of PTC and MTC in children. And interestingly enough, the Children's Oncology Group did a phase 2 study of sorafenib in refractory solid tumors, of which patients with thyroid cancer were eligible to participate. It was 200 milligrams per meter squared per dose, and they enrolled 20 patients. Unfortunately, none of the patients had thyroid cancer. So we weren't able to really ascertain how well that drug would work in those patients. There was no objective response seen, but there was no excessive dose-limiting toxicity observed either. So I don't think we would take sorafenib off the table just yet for these patients. So a majority of our patients have excellent outcomes with surgery and radioactive iodine treatment, but we know that the MAP kinase pathway has a key role in the development of thyroid cancer. So we're going to probably start seeing an increased use of these multi-kinase inhibitors. What's our impact? Well, as you are aware, they're not FDA approved for children. What's the actual dose that we should be given to children? And then, of course, a lot of these agents, you know, as we increase the use of oral agents, we don't always have a extemporaneous compound on the shelf ready to pull off and give to our kids. So actually trying to deliver these agents to, you know, 3- and 4-year-olds can be quite challenging. But I think there's opportunities for us to be involved in research, actually looking at trying to compound some of these oral agents into extemporaneous compounds, and then giving these agents to children and monitoring them for their effects and being able to report those in the literature, I think will be very helpful to our colleagues. Moving to supportive care, talk a little bit first about filgrastim. This was the second of 2 plenary papers, so this was also rated extremely high by the the committee when they received all the abstracts. And basically this investigation is looking at what is the optimal time to start G-CSF. As we all know, chemotherapy-induced neutropenia occurs. It's associated with increased morbidity, namely fever neutropenia. We have to augment our treatment plan sometimes, whether we interrupt therapy, omit doses, or decrease doses, which we know doesn't have necessarily positive outcomes when we have to decrease our dose intensity for patients. But we do use filgrastim to offset these toxicities. So the investigators looked at using post-chemotherapy filgrastim and whether or not they could delay the administration of filgrastim without affecting neutrophil recovery. So this was their study. It was a randomized prospective two-treatment, two-period crossover design. Patients were randomized at the end of chemotherapy to receive either standard G-CSF at our usual 5 micrograms per kilogram a day, that was started 24 hours after the conclusion of chemotherapy, or to delayed G-CSF, where they got 5 micrograms per kilogram daily, only started when the ANC fell below 1,000. All patients stopped once the ANC rose to above 1,000, and all patients were crossed over for the next treatment cycle. So the patients served as their own controls. This study enrolled patients between the ages of 1 and 25 years of age and included high-risk or recurrent solid tumor patients. So demographics, 21 patients were enrolled. Most of the patients had a solid tumor, as you can see, and as such, the chemotherapy regimens are ones you would expect to see for solid tumor patients, usually an oxazophosphorine, sometimes given in combination with a platinum compound. 14 patients were eligible for analysis in this study. As you can see, the time to neutrophil recovery did not vary between the two different groups, about 15 versus 15.6 days. However, the total number of filgrastim doses did. For those patients that had delayed filgrastim, they received approximately 4 fewer filgrastim doses than those patients that were started 24 hours after chemotherapy. In both of these schedules, the ANC recovered about 2 weeks after starting G-CSF. When they looked at the incidence of fever and neutropenia, most of the patients didn't have an episode, whether they got delayed G-CSF or standard G-CSF. 3 of the patients had episodes of fever and neutropenia regardless of schedule, so they had it with standard as well as with delayed. What was concerning was one patient, as you can see here, had fever and neutropenia with delayed filgrastim but not standard, but this was offset by this one patient down here that had fever and neutropenia with standard administration but not the delayed administration. The authors did not offer the incidence of other side effects such as bone pain or headache, so I can't comment on that. So when should they start filgrastim? They found that the start time difference between the two groups was about 8 to 10 days. So they conclude that delayed filgrastim administration might result in approximately 4 fewer doses without a delay in neutrophil recovery or increased incidence of febrile neutropenia. They do know that they probably have to do a larger study, which I believe is in planning stages right now. And for us, obviously, this allows for us to do some potential cost savings. If we can admit about, on average, 4 doses of filgrastim, that can have significant cost savings, not to mention patient and caregiver quality of life. That's 4 fewer pokes, as our patients like to say. So what are some future directions? As I mentioned, some additional studies are going to have to be undertaken, but someone in the audience did question, well, what about the role or the use of biosimilars in this patient population? They didn't look at using biosimilars in the study itself, but that's something to consider as they become available on the market, particularly if they are cheaper than the originator product. Little word on sinusoidal obstructive syndrome, or SOS. It is a potentially life-threatening complication from hematopoietic cell transplantation. I've summarized the pathophysiology here. As you're aware, injury from high doses of chemotherapy to the sinusoidal endothelial cells, hepatocytes, and stellate cells. In turn, in the venule causes microthrombosis, fibrin deposition, ischemia, and fibrogenesis, which in turn systemically causes portal hypertension, hepatorenal syndrome, and multi-organ failure. So this is something that we often see and we often attribute to patients undergoing stem cell transplants. But what we're also finding is some of the patients don't necessarily have to have undergone a transplant to experience this. So defibrotide was just FDA approved in March of this past year for the treatment of both adults and children who develop SOS or veno-occlusive disease with additional kidney or lung abnormalities after they receive a stem cell transplant. This data was from 528 patients treated on 3 different treatment IND studies. But there, as we know, several chemotherapy agents have been associated with the development of SOS. And we really don't truly know the incidence of SOS following combination chemotherapy only, nor do we really know what patient outcomes are once they do develop SOS. And we're not quite sure of how people are treating or managing these patients. So it's not well characterized, the treatment or management for these patients who do develop SOS outside of stem cell transplantation. So Dr. Kernan and her colleagues looked at this data from the treatment IND study. And through April 18, 2015, they enrolled 857 patients. They were able to pull out 101 of patients, or almost 12% of the population, that received chemotherapy without a stem cell transplant. So these were chemotherapy-only patients. They still received defibrotide 6.25 milligrams per kilogram IV every 2 hours, every 6 hours for at least 21 days. But the only difference is they did not receive a stem cell transplant. So what did they find? Well, as you can see, about half of the patients had sinusoidal obstructive syndrome with multi-organ dysfunction, and about half the patients did not have multi-organ dysfunction. A little bit more males in the patient population than females, and more of the patients also had leukemia diagnosis. 80.2% of the patients in this group of 101 patients were under the age of 16, so they were considered pediatric patients. And the largest group was those patients ages 2 to 11 years of age, almost 73% of the study population. Again, the underlying diagnosis here isn't surprising. It's mostly ALL and AML, although there were a smattering of solid tumors that were found in the study population. I've listed here the chemotherapy agents that were reported in more than 30% of the cases, and vincristine was the leading agent to have been given to patients who develop sinusoidal obstructive syndrome. Other agents are listed here. What was interesting, for those patients that received inotuzumab ozogamicin, there were only 2 patients who developed sinusoidal obstructive syndrome that were enrolled on this treatment IND. The Kaplan-Meier estimated day 100 survival was about 77% for the total study population. Of course, it was improved, as we would expect, in patients without multi-organ dysfunction compared to those patients that had multi-organ dysfunction. And then when we look at the day 100 survival with patients who either had multi-organ dysfunction or without, and compare them from pediatrics to adults, pediatric patients did better overall in all categories compared to adult patients. It was probably more often that patients without the multi-organ dysfunction started the study drug earlier, so that's probably one of the reasons why they did better. So here is the toxicity data, and in the interest of time, I won't go over everything in detail, but just to point out, the events were similar to what was seen in the hematopoietic stem cell transplant, that there were no cases of serious GI bleeds or CNS hemorrhage in this patient population compared to those patients who had transplants. So clearly, sinusoidal obstructive syndrome is not limited to the setting of a hematopoietic stem cell transplant. Defibrotide therapy was very well tolerated. It's unlikely that a phase 3 study will be performed in pediatric patients experiencing SOS following chemotherapy. Dr. Kernan said that there's too many challenges to undergo such a study, so this is probably one of the most robust data that we have to date. But as far as our role or pharmacy impact, obviously if we start using this in our patients, we can continue to contribute data to the medical literature to add to the information that's already at hand. Also, it's a chance for us to get involved in guideline development and supportive care practices now that it is commercially available. Of course, we have to keep in mind the cost versus the value. Recently, there was some chatter on the ASPHO listserv that for a 200 milligram vial, its institution's cost was about $825. So clearly, it's not something that's inexpensive, but if it can avoid prolonged hospitalization, ICU admission, or increased utilization of resources, its cost may be justified. Moving on to prevention of mercaptopurine-induced hypoglycemia. This is a study that was presented in poster format by Texas Children's Hospital. They had a case report I found very interesting. Just to refresh your memory, taking you back to biochemistry, mercaptopurine here, the metabolism I have laid out. What you need to know here is the 6-MPP metabolite is thought to be responsible for the hepatotoxicity that we see in the patients, and the thioguanine nucleotides here is what we see as producing the anti-leukemic effect, as well as some of the myelosuppression we see in patients. It's been reported that mercaptopurine can cause hypoglycemia, but the use of allopurinol has been shown to reduce levels of 6-MMP, so the hepatotoxin here, without affecting 6-TG levels in ALL patients. This proof of concept of using the two drugs together was actually shown in adult patients with inflammatory bowel disease. So this is something that the investigators undertook in a pediatric patient with ALL. He was enrolled here on the AALL-0434 study. He received 75 milligrams per meter squared per day of mercaptopurine, had no prior history of hypoglycemia, but had several cases of severe emesis, wasn't tolerating the therapy very well. As you can see here, had worsening vomiting and dehydration. They did an ACTH test, but no evidence of adrenal insufficiency was noted. He did have increase in his ALT, and then also the 6-MMP level, when they measured it, was almost 59,000. The reference range that I have listed here is expected to be below 5,700. This reference range is from the inflammatory bowel disease literature. So the reference range has not been established for patients with acute leukemia, although it's been noted that patients with ALL tend to experience hepatotoxicity when the 6-MMP level exceeds 5,700. So they described their management of this patient. First, they changed the mercaptopurine administration time, going from evening to morning. They changed the patient's diet to include high carbohydrate foods, including cornstarch at bedtime and a 3 a.m. snack, as well as splitting the dose of mercaptopurine into two. And then finally, the intervention they used was the addition of allopurinol, 50 milligrams per meter squared per day, concurrently with a dose reduction in the mercaptopurine by 67%. So they dropped that dose down from 75 milligrams per meter squared per day down to 25 milligrams per meter squared per day. And you can see the results here. With each of the interventions, they had a decline in the 6-MMP level without significantly affecting the 6-TGN level. So they had resolution of hypoglycemia and marked improvement in nausea and vomiting. The patient was able to resume a normal diet, and they could escalate the 6-MP dose to decrease the patient's ANC without a recurrence of symptoms. So this work further supports elevated 6-MMP levels as the etiology behind mercaptopurine-induced hypoglycemia. For those of you who review pediatric blood and cancer, you do know that a recent publication just came out in the past few months looking at the same combination to manage patients who have 6-MP-induced pancreatitis. So we're seeing this being used more widely. As you can see, though, pharmacy impacts, we need to reevaluate this known drug-drug interaction. I mean, many of us know that we tell our pharmacy students, oh yeah, don't give 6-MP and allopurinol, or if you do, proceed with extreme caution. So this is going to take a lot of staff education to let them know that the rationale behind its use and how to manage these patients. So then moving on to survivorship, I have 3 points I want to raise with survivorship. There was a nice educational component of when survival isn't enough, and one of the interesting highlights of that session was the introduction or the summary of survivorship guideline harmonization. So as we know, majority of children and young adults survive their cancer. We know that there are many survivors, probably close to 500,000 pediatric survivors in this country alone. But survivorship guidelines exist, but often vary. And they vary based on the evidence linking late effects with therapeutic exposure as well as screening recommendations that really just relies on expert clinical experience. So this group, the International Guideline Harmonization Group, formed in 2010, recognizing the need for collaboration. And this is a worldwide endeavor to collaborate in guideline development. There's 4 national guideline groups, the Children's Oncology Group, the Dutch Children's Oncology Group, the UK Cancer and Leukemia Group, and the Scottish Intercollegiate Guideline Network that came together, working with the Cochrane Childhood Cancer Group in partnership with the PanCare SURFUP Consortium, which is part of the European Union. Basically, their guideline development is trying to take the knowledge that they have and transforming it into recommendations based on the best research evidence, clinical expertise, and patient concerns. There are 5 key recommendations or issues that they go through each guideline, and so I have them listed here. In your appendix, I have a little bit more of the history of this group as well as their methodology, and I refer you to their website here if you really want to look deeply into the methodology. They have a nice handbook on how they go through all of their guideline development. So the example that they gave during the session was a recently published guideline on cardiomyopathy. They divided patients into risk groups, low risk versus high risk, and you can see the features. And they found that the general recommendations essentially are survivors and caregivers too should be aware of the risk of cardiomyopathy, and that we should be screening for modifiable cardiovascular risk factors in our patient population. So watching our patients for diabetes, watching them for hypertension. Who needs the surveillance? They come up with if it's after anthracycline therapy or after chest radiation therapy. And it's basically based on the amount of radiation or anthracyclines received. So the highest risk group here is the 250 milligrams per meter squared. And then for radiation, it's for 35 gray or higher. So those patients high risk is clearly recommended. It's reasonable in patients at lower risk and maybe reasonable for those patients at the lowest risk. Which modality should we use? We recommend using ECG or echocardiograph for the primary modality to assess left ventricular systolic function. This was not based on specificity or sensitivity, but just rather on availability and cost. So the cost and value ratio was quite favorable to recommend ECG. Alternatively, you can use radionuclide angiography as well as cardiac magnetic resonance imaging in patients who you cannot do an ECG on. But to draw your attention, you do not want to use cardiac blood biomarkers solely as your modality to monitor patients for cardiac dysfunction. I know it's pretty easy to draw a BNP, but we really don't want to rely heavily or solely on that alone. When do we start and what's the frequency? Here, recommended to start no later than 2 years from completion of therapy and repeat it 5 years after diagnosis and continue 5 years thereafter. For those patients not at great risk, you can do a little bit more, or for those patients at high risk, can do more frequently or lifelong as well. But clearly, you start at least 2 years out at the 2-year mark, and you do it 5 years after diagnosis, and then every 5 years thereafter. What interventions? These guidelines do not give specific interventions or treatment recommendations. They just make those available for people to know that they are aware that they are available, but cardiac consultation is recommended, and then whether or not you start a beta blocker or ACE inhibitors, that may be reasonable for patients depending on other factors. They also have advice regarding physical activity. We often get questions about this. We have patients now doing extreme sports, So what's the recommendation? Well, clearly physical activity is recommended for patients. Do it regularly, but you really should do this in concert with cardiology consultation. So future plans are going to complete on some of the panels that are ongoing. Again, in your handout, I have other ones listed for you. For our impact as pharmacists, it's clearly patient monitoring and education. After patients do come back to a survivorship clinic, we're making sure that we're following them. And then we have an opportunity for research opportunities, monitoring patients long-term for their cardiac risk factors as well as their sequelae. So the last ARS question, RW is a 23-year-old Hodgkin's lymphoma survivor diagnosed 8 years ago. He's considered high risk for the development of cardiomyopathy and currently is asymptomatic. Which of the following recommendations is strongly advised for him? To avoid isometric exercise, yearly assessment of blood cardiac biomarkers, echocardiography every 5 years, or start prophylactic enalapril 5 milligrams orally daily. So the correct answer is echocardiography every 5 years would be the thing that's strongly advised for him. So speaking of cardiology and cardiotoxicity, the introduction of ALTE 1621, the carvedilol study, was summarized at the ASPHO meeting. As we know, a growing number of patients are surviving their tumors. They're at high risk for cardiovascular complications. And the risk for cardiovascular disease in survivors compared to healthy siblings is quite high. So we really, of course, as we know, need to be monitoring our patients. We know chemotherapy is the leading cause of cardiovascular disease in cancer patients, and anthracyclines are known to cause that cardiotoxicity in a dose-dependent fashion. We do have preventative measures, but they've been met with variable success. In the Duchenne muscular dystrophy patient population, these patients are at risk for dilated cardiomyopathy later in life, and perindopril has been shown to prevent some of the cardiovascular complications. So this is a proof of concept, if you will, that allowed the COG to undertake the study of the Prevent Heart Failure study. So this is a study. We'll look at the highest risk of patients. They have to have received anthracyclines more than 300 milligrams per meter squared. They'll be randomized based on age of diagnosis, time for treatment, and chest radiation. Half the patients will go on to receive carvedilol. You have a 2-week run-in period at low dose, then 1 month at 6.25 milligrams daily. And as long as the patient's tolerating that dose, they'll go on to receive the maximum of 12 milligrams per day. And they'll receive this for a total of 2 years. The other half of the patients will be placed on placebo. Patients must be diagnosed before age 21, and they have to be at least 2 years out from completion of treatment. There's an extensive list of exclusion criteria, so I refer you to the protocol for these, but 2 notable ones. Anyone with prior treatment with dexrazoxane cannot be included. And then for females, you have to be at least 50 kilograms, and for males, you have to weigh at least 55 kilograms. So we don't have to worry about a weight-based dosing because we're just using the standard low dose that you can see in adults. So the primary aim here is, can we really look at reversing the remodeling seen in children at high risk for cardiotoxicity after chemotherapy? Of course, we'll look at safety and tolerability, and then looking at the risk-benefit ratio from this 2-year intervention. It is interesting, this is an interventional study. Most of the long-term relate effect studies through COG have been observational, but this is something new. So this is actually an interventional study. Current study status, this falls under central IRB review. Patients don't have to be enrolled in another COG study to participate. Randomization of the study is being done by Sharp Pharmaceuticals as well as the drug dispensing. So the Children's Oncology Group has purchased carvedilol, but Sharp Pharmaceuticals is doing the randomization and dispensing to keep this double-blinded. The study opened in April 2016, and as of the ASPHO meeting, there were 18 centers already participating in the study. If you'd like to participate or have questions, here is the contact information. And from a pharmacy perspective, obviously this is a supportive care intervention that we can offer patients and try to improve their accrual and enrollment on study. And then finally, we'll talk about response to vaccination in childhood cancer survivors. As we all know, childhood cancer survivors have variable retained immunity after treatment. By 6 months after treatment, most of the patients do have their count recovery, but some of the patients actually have dysfunctional recovery or a really longer delayed in recovery, particularly if they receive high-dose chemo or steroids. We have seen outbreaks of vaccine-preventable diseases. Most recently was in the late 2014 in Anaheim and Disneyland with the measles outbreaks. And we really don't have robust guidelines that exist for cancer patients in terms of revaccination schedules. So the group at Memorial Sloan Kettering looked to prospectively evaluate the response rate of protective titers in cancer survivors. Here's the eligibility criteria. About half of the patients pretty much evenly split between male and female. Wide range of ages. Most of the patients had a hematologic malignancy that were enrolled on the study. So there were 3 vaccination schedules that were utilized based on age, and I have included each of the schedules in your appendix for more detail. 36 of the patients completed all the planned scheduled doses. 19 of the patients had at least 75% of the protocol administered, and 22 completed less than 75%. Median start time was 3 months after treatment. And what I found very interesting about this is the fact that primary disease was not predictive of response to vaccination. So we often think children with cancer have suppressed immune function as a result of their disease, particularly with malignancies of B and T lymphocytes. But it really didn't matter if you had a hematologic malignancy or if you had a solid tumor, whether or not you responded to vaccination. Here is their results. You can see in the blue bars are their baseline titers in their patients, and the orange bars are the post-vaccination titers. Very robust for some of these, 100% titer achievement in tetanus, diphtheria, polio, and hepatitis B and Haemophilus. Some of the other ones here listed not so robust. And then if we go to the next slide, you can see here the measles, mumps, and rubella. The needle didn't move too much in these patients from baseline to post-vaccination. And clearly from varicella and the meningococcal agents here, although they did see a huge move of the needle from baseline to post-vaccination, a lot of these patients still remain unprotected. So you still need to do surveillance in this patient population. So the conclusions that the authors had were poor residual immunity to childhood vaccines following chemotherapy. Titers are not necessarily in patients where immunity is expected to occur in 100% of patients following revaccination. So those are your tetanus, diphtheria, polio, Haemophilus, influenza B, and hepatitis B patients. Again, post-vaccination titers, though, remain suboptimal with some groups, and so you're going to have to do ongoing surveillance, your measles, mumps, rubella, vaccination, varicella, your pertussis, and your meningococcal. Clearly, ongoing studies are necessary, and we do have a role in pharmacy, not only in patient monitoring and pathway development with coming up some of the vaccination schedules, but also the product stocking and selection. There's a lot of vaccines that are out there, and so especially with the combination products, the questions come up, should we have the combination product, should we not? Recently, we just learned that, flu mist shouldn't be given to the patients because they're not getting the coverage that they would expect. So some of the patients, you wouldn't want to use that, obviously, but also their family members, you probably don't want to do that as well. I did include a link to the CDC guidelines in your appendix, and there is a website out there I find very useful called immunize.org. They have a lot of apps for your smartphones and your tablets, so if you want to download some of the apps that have a lot of these recommendations, they might be very helpful. So just in summary, thank you again for hanging in there. Recent research results have demonstrated really a lot of innovative methods to caring for children with cancer and their survivors. And then we have emerging data, and we are expecting that to impact our practice as pharmacists. But as pharmacists, I think we really do have a leading role in implementing a lot of these practice guidelines developing pathways, obviously formulating order sets, and then product selection and stocking of these products. So with that, I will take any questions. I don't see anything in the chat box, but if anyone has any questions, I'd be happy to answer them.
Susanna, can you see the question that I posted there now? One came in through private message.
Let's see. Okay, let me go here. Let's see here. It says, the question came in through private. What is the definition of delayed G-CSF administration, and is there a maximum time frame? So the authors define delayed filgrastim administration as those patients who did not start G-CSF until their ANC fell below 1,000. So they didn't have any really time frame that they gave. They didn't say, well, 3 days versus 4 days. They just waited until that ANC fell below 1,000, rather than just knee-jerk reaction, hey, my patient's 24 hours out from chemotherapy, I'm going to start filgrastim. And that would be considered standard in their study, that at 24 hours after chemotherapy is concluded, they started the filgrastim. But in the delay, they had to wait based on the patient's ANC.
If we have no further questions, we can conclude today's webinar. Thank you for joining us.
Thank you.